I am now pleased to introduce our first speaker, Dr. Natalia Chalmers. Dr. Chalmers is the first ever Chief Dental Officer in the Office of the Administrator at the Centers for Medicare and Medicaid Services. She's a board-certified pediatric dentist, oral health policy expert, and public health advocate, and she brings more than 20 years of clinical, research, industry, and regulatory experience to her role. We're so honored to have her with us today to share CMS's vision for oral health. Dr. Chalmers?
Thank you, Catherine, for this kind introduction. It is truly an honor to join you with my fellow panelists and reflect on how we can address oral health disparities and access to care. Next slide, please. I've titled my presentation, Oral Health, an evidence and data-driven approach to achieve better health, equity, and fiscal responsibility. And I hope we'll all jointly explore the evidence around the importance of oral health. Next slide, please. I would like to take a moment to share the CMS vision for the future. Our administrator, Chiquita Brooks-Rashore, has developed an inspiring vision that CMS will serve the public. As a trusted partner and steward dedicated to advancing health equity, expanding coverage, and improving health outcomes. The first pillar to support this vision is that we will advance health equity by addressing the health disparities that underline our healthcare system. The second is to build on the Affordable Care Act and expand access to quality, affordable health coverage and care. The third one is to engage our partners and the communities we serve throughout the policymaking and implementation process. The fourth one is to drive innovation to tackle our healthcare system challenges and promote value-based, person-centered care. I'd like to refer you to the CMMI website to see their vision and white paper on the future of innovation in CMS. The fifth pillar has to do with us being the stewards for these programs. And so we will protect our program sustainability for future generations by serving as responsible steward of the public funds. And last but not least is to foster a positive and inclusive workplace and workforce and promote excellence in all aspects of our operations. Next slide, please. I think this slide says it all. The Surgeon General was very clear when he said, "You are not healthy without good oral health." I would like us to keep that in mind as we move forward, trying to address disparities in our healthcare system. Next slide, please. Three things I hope you come away with. The first one is that oral health is about equity, and we'll explore this further. But it's also about fiscal responsibility, and when oral health needs are not addressed early, we end up encountering costs in the healthcare systems that are avoidable. And last but not least, oral health is about inflammation. And if we were to improve clinical outcomes, we need to address unmet oral health needs. Next slide, please. This is a trend of the prevalence of untreated tooth decay in primary teeth among children ages 2 to 5. As a pediatric dentist, I've treated many of these children, and some of them are pre-cooperative and require additional support so that the treatment can be performed. But we have amazing strategies in prevention that work really well and have to be employed to address these disparities. See the gray bars. You know, this is the level of racial disparities that exist, where 15% of Black non-Hispanic children have untreated tooth decay, compared to about 7% in white non-Hispanic children. And also you can appreciate the income disparities on the right, 17 for children living below the 100% of federal poverty level, compared to only 6% of children living over 200% of the federal poverty level. Next slide, please. These disparities persist throughout the adulthood. And you heard in initial stats on the prevalence of periodontitis, but here we see that broken down by age from 30 to 65. And take a note at that figure that 65 years or older people in the blue bar, 66% of them have, thank you, periodontal disease. And you also can appreciate the racial disparities that exist with periodontitis, where non-Hispanic Blacks have rates of about 60% of periodontitis compared to 40 with non-Hispanic whites. And as with the children and the untreated cavities, again, you see adults in poverty have a prevalence of periodontitis around 60% compared to only 30, those who live 400% above the federal poverty level. Next slide, please. And that continues as people age. And in adults 65 years or over, complete tooth loss, or also known as edentulism, increases with age. There are not significant differences between men and women, but the racial disparities are quite clear. 30% with non-Hispanic Blacks experiencing edentulism compared to 16% with non-Hispanic white, or 15 with Hispanic. It is encouraging to note that there has been an overall reduction in total prevalence of edentulism, but we need to address the health disparities. Next slide, please. This is a really clear picture of the progress we have made in access to dental services for children in poverty. You would appreciate the change over the last 16 years and increased access to care for children living below the federal poverty level. But notice how in the middle, there is very little change for both adult groups. And on the right, adults who live below the federal poverty guidelines have seen no improvement in access to dental services, while there have been increased access to care for adults living above the 400% of the federal poverty level. Next slide, please. I think one of the primary challenges for oral health and our integration with the healthcare system is that these clinical scenarios are perceived very different by patients and providers. So on the right, you see a non-healing ulcer over the ulnar aspect of the left forearm. And clearly it's inflamed and swollen and oozing. And on the left, you see someone who has chronic periodontal disease. What goes underappreciated is that the total inflammatory surface around the teeth on the picture of the left would result to an ulcer of that size, and many times that goes unnoticed. So you would never imagine someone presenting with this level of inflammation and a clinician says, oh, let's take care of your diabetes, right? And this has been the challenge to communicate how these two conditions for the body are identical. The body doesn't know where the inflammation started. It reacts the same way. Next slide, please. Periodontal disease is associated with many inflammatory comorbidities, such as cardiovascular disease, type 2 diabetes, rheumatoid arthritis, inflammatory bowel disease, Alzheimer's, non-alcoholic fatty liver disease, cancers. And the way the periodontal pathogens disseminate is through the blood, so that's called bacteremia, or through the oropharyngeal and oral digestive pathway, resulting in increased inflammation and exacerbation of these conditions. And if you're in healthcare, you know that the majority of our resources are trying to address these conditions, and yet we don't address the periodontal disease that's fueling the inflammation. Next slide, please. Poor oral health has also impacts beyond healthcare. If you have poor oral health, it will be an obstacle to employment. It is the #1 reason why children miss school days, and also it impacts their performance. Poor oral health is linked to substance use disorder, and that connection is actually bidirectional because many substances negatively impact oral health. And it's also Poor oral health is a independent predictor of all-cause mortality. So just to keep that in mind when we talk about the impact of poor oral health on the well-being of our beneficiaries. Next slide, please. It is important to reflect where our beneficiaries present with oral health care needs. On the left, you see the dental delivery system with many well-established patients who have access to care and the occasional patient that shows up to the front door of a dental office only when they have a problem. When oral health care needs are not addressed, many of them exacerbate and patients then present to the emergency department with oral health care needs. Again, some of them will show with one emergency, but many will return. When the condition is so poor, some of them have to be admitted into the inpatient admission, right? And now we are moving from the fiscal point of view from a visit that in the emergency department on average can cost $900 to an inpatient cost that could range from 10, 20, 30, depending on the state. The ambulatory surgery point of care is a really important one for very young children, as pointed in the beginning, but also for children and adults with special healthcare needs. Urgent clinics are also point of care, and you will hear later in the program how schools serve as an incredible opportunity for access to healthcare for children. We have to talk about the health information technology divide, the lack of diagnostic coding between the two systems, and how we need to integrate and coordinate care better. Next slide, please. For children enrolled in Medicaid, dental services are essential and provided. However, you can see here that the percentage of Medicaid eligible children 1 to 20 who receive a preventative dental service in 2019 varies dramatically by state. And that is to say that benefit and coverage alone is only the first step. And there are many barriers that need to be overcome to ensure access to care. Next slide, please. One incredibly useful opportunity is to understand the dental and medical utilization and seek opportunities for collaboration. On this slide, you see the total and broken down by the age of the beneficiary utilization of dental services and medical services. First, what is really clear is that the overall utilization is very similar, but there are two different trends. The dental following this U-shaped utilization with very low in the early ages, where medical using this slope utilization. And so it presents a unique opportunity to intervene early on and collaborate with our medical colleagues to advance oral health services in a non-dental setting. Next slide, please. From the early and periodic screening diagnostic and treatment report that states provide for children 1 to 2, you can see this is the state's geographic variation of oral health services by a non-dentist provider. Again, you can appreciate the differences between the states and the states that are hatched over are now engaged with the Centers for Medicaid and CHIP services in a learning collaborative of how to advance the prevention and reduce childhood caries. More information about the collaborative is available on medicaid.gov. Next slide, please. It is important to understand dental expenditure of the healthcare system in the broader healthcare expenditure, and you will see that that accounts for about 4% or $124 billion. But note the circles, the two circles in red, right? This is for physician services. We have out-of-pocket spending about 9%. For dental, it's 40%. And the other piece that many of you will be familiar in the Medicare space for physician services is about 23%, and for dental, it's 0. Next slide, please. Thinking about the priorities and spending in the healthcare system, the striking differences between the public, private, and out-of-pocket systems, if you will. We spend the most in diabetes in the public space, about $55 billion every year, and I already highlighted how oral health is connected to that. But you see oral health spending ranks 34th and 47th. In the private insurance business or the private delivery system, Oral health services rank 11 and 12, and diabetes is now at number 5. But in the out-of-pocket spending, oral health and well dental services are number 1 and number 2. Next slide, please. For Medicare beneficiaries, this is from a survey that's conducted by the Centers for Medicare and Medicaid Services. We understand their expenditures, total expenditures, and also out of pocket. And again, if you see, they spend about $4,000 on prescription drugs, about $3,000 on physician services, and so forth. And when you compare, yes, when you look at the out-of-pocket proportion, you would appreciate the dental services have the highest out-of-pocket rate. Next slide, please. And so one opportunity that is really clear is to address the emergency department visits for dental needs. Because they are about equity, they have a huge fiscal impact. They contribute to many readmissions, they're linked to mortality, and last but not least, to many opioid and antibiotics prescribing. Next slide, please. The chart on the right clearly indicates who is the primary payer for these conditions. In 2014, Medicaid became the primary payer for emergency department visits for dental conditions among adults. And you will see on the chart on the left, the age group most impacted by this is ages between 19 and 34, these two age groups together. Why is this important? Because, next slide, please. Dental pain is one of the #1 reasons why opioids are prescribed to adults that present to the emergency department. Here you see an unsettling trend for over 10 years where dental pain and kidney stones are sort of playing tag and tag, and dental pain is still one of the top reasons for opioid prescribing. So it's not only impacting the overall health, but it's fueling the opioid epidemic. Next slide, please. And so the Centers for Medicaid and CHIP Services released last week a comprehensive study on the Medicaid adult beneficiaries emergency department visits for non-traumatic dental condition. That study is available on our site and will be shared with the materials after the webinar. Key findings of the report examine the emergency department visits for non-traumatic dental conditions for Medicaid non-dual adults. And in 2018, there were approximately 663,000 such emergency visits, and approximately 7,500 of them resulted in an inpatient admission. And we report this by state, both the inpatient admission as well as the emergency department visits. So next slide. So looking ahead, what are some of the challenges and opportunities? We have had we have been in the middle of a pandemic for now 20 months or so. The foregone care is not something that will leave us quickly. Many children, so COVID-19, we heard in the beginning, has impacted access to many services, but compared to pre-pandemic level, we're still about 30% below where we were. So that is a huge, if you will, accumulating burden that we will have to face sooner or later. We have increased enrollment, and you'll see these by the recent reports on Medicaid.gov. We have to think about system capacity, right? How innovative approaches such as telehealth could help us address unmet needs. What is the role of school-based programs? And you'll hear from my fellow panelists of some innovative ideas. Thank you for your attention, and I look forward to your questions during the question and answer session.
Thank you so much, Dr. Chalmers, for highlighting some of the key challenges and opportunities for reducing disparities. And we look forward to continued conversation and questions with you at the end of the presentations.